Beyond breakout session, you are in the right spot. Our speaker this morning for in vitro is Dr. Celeste Braybeck, who works with Reproductive Resource Center, and RRC is also one of our platinum sponsors this year. And please give a warm welcome to Dr. Braybeck.
Just testing. Can you hear like that? Is that all right? Good morning. So glad to have you all here. At least it's not snow, right? And tomorrow going to be 75 and sunny, so we're here the right day. Anyway, I want to give a great, and too bad your whole group is not here, Allison, because I cannot speak highly enough of this whole group. Kansas City Infertility Awareness, this group of women is phenomenal. And this is my third year here as well, and it is just fabulous. So I've seen them from before these stories that you just that they just told you, okay? And I have a really great team of workers that's with us, but if any of you, Allison, on your group need any marketing work or job, I will hire you in a heartbeat for projects because they are phenomenal. Anyway, so glad to have you here this morning. I'm Dr. Celeste Braybeck with Reproductive Resource Center. Our office is located in Overland Park, and it's near the intersection of 435 and Quivira, so near the campus of Overland Park Regional. But we're delighted to be here with all of you this morning, and we serve the whole Kansas City metro area, and we actually serve about 5 states. So we see patients in Kansas, Missouri, Arkansas, Nebraska, and Iowa on a regular basis. So very glad to have you here. I thought I'd talk just a little bit about kind of the history of infertility, particularly IVF, and kind of where we are today, because there's been amazing changes, and amazing changes just in the last year or two. So I know nobody wants to be here. Everybody wants to be a former infertility patient, not a current one, or currently infertility. But if you had to pick a time in history to do it, you picked a really great time, because there's a lot of exciting things going on that are just very, very new in this last year. Okay? So some of you might have already done IVF. Some of you might not even know what it is. And some of you might be thinking, IVF, I really don't need that. That sounds like it's big words and it's really expensive. But it's interesting. In 2013, again, the treatment path has changed a little bit. Most couples will probably start with really low-tech kind of things like oral medications like clomiphene, or letrozole, or IUI, intrauterine insemination. So most people will start there and do a few cycles. And it was not uncommon way back when to do 6 or more cycles of those kind of things before moving on. But what has happened is, as data has accrued and time has gone on and science has changed, we have learned that moving to IVF sooner rather than later actually costs you less, gets you a baby faster. And so it might be something that you might have thought, hey, I never want to do that, I don't want to think about that, we can't do that. That it's just have a little open mind. Again, whatever way you get there, and every path is different. And whether it's trying on your own, whether it's doing ovulation induction with insemination, whether it's doing in vitro, whether it's doing donor egg, donor sperm, or adoption, or choosing to be child-free, all of those things are good. And each of you will have your own individual path. So IVF, what is it? For those of you who aren't familiar, kind of beginners in the room, IVF is just a fancy acronym, and we have so many acronyms in this field that it just gets overwhelming, so I'm sure it is if you're kind of new to infertility. Standing for in vitro fertilization. And those words just mean that we put an egg and sperm together in a laboratory setting, rather than fertilization that happens naturally in the body. So that's all we mean when we see in vitro fertilization. Indications, which means a fancy word for saying why might we want to do IVF, really began in the very early days with tubal factor infertility, because if both tubes are blocked, then there's nowhere for that egg and sperm to get together, because that's where they typically fuse. So in the very early days, in the late 1970s, tubal factor infertility was really the only reason we ever did IVF. And since that time, as pregnancy rates have increased, IVF is used for many, many reasons. And it works very, very well for many reasons, and even works very well when there's unexplained. So I want to talk just a little bit about the history to say, hey, where we started and where we are today, to give you some of you kind of a glimpse. So the first IVF baby was born in Great Britain in 1978. So that was 35 years ago. And our center's been around for 25 years, so we've enjoyed most of the scientific advancements. So 35 years ago. And the very early pregnancy rates were low. We were lucky if we could get 10% in those days, And at that point in time, we were putting every single embryo made back into the female, and we were doing it one day after getting it out. Because at that time, science did not know what the growth requirements were for an embryo. And so we were really afraid to have an embryo in the lab very long because we really weren't sure of what the nutrients are that are needed. And again, those pregnancy rates were low, required to transfer all the embryos, and so therefore, not only was it low, if we were pregnant, there was a chance of a high order multiple pregnancy. That's totally, totally different today. Just to give you some idea, today we can put one in, and with some of our treatments get pregnancy rates of higher than 80% in one try with one embryo. So an entirely different day. IVF works really great for tubal factor. It also works quite well for endometriosis. It works well for male factor, but not severe male factor. And male factor is not uncommon. About 40% of couples have male factor. So not uncommon, and it's kind of good, I think, for couples because then nobody alone needs to feel it's all my fault. It's not all her fault, it's not all his fault. We kind of might both play a role. But anyway, when there's very severe male factor, IVF never worked well. But in the early 1990s, ICSI, where we inject a single sperm into a single egg, was first done. It was first done in Belgium. And it allows men with severe male factor to father a child. And by severe, I'm not talking 3 million, I'm talking 3. Maybe 3. We would have to take 4 hours to find them. But with single-digit sperm counts, we can actually get pregnancy rates really identical to those of men with normal sperm count. So that was really a nice advance. Then in the late 1990s, blastocyst culture was invented. And that's a fancy word for, remember the first part I said we used to just culture for one day and we'd put every embryo in. Later on, we were putting embryos in after 2 or 3 days. Well, in the late 1990s, we started growing out embryos longer because what we learned was that in normal fertilization, in normal implantation, the embryo takes its time. It takes a pokey journey from getting all the way from the ovary, back to the uterus. And it takes about 5 days, 5 days in the fallopian tube. And so by putting an embryo in after 1 or 2 days, the uterus really isn't ready. It isn't really at its prime implantation potential. So we started growing out embryos for 5 days, knowing that that is the best time for implantation of the uterus. And when we did that, it was amazing because we were putting in fewer embryos. We started putting in fewer embryos and still getting more pregnancies. By that I mean more 1 or 2 baby pregnancies. So we could put in only 1 or 2 embryos and get much higher pregnancy rates by growing embryos out longer. Now growing out embryos longer is not easy because that means there's a lot of pressure on the IVF lab and culture conditions to be good and adequate, that sort of thing. But that was a huge advance, and I'm very proud to be part of a team that did the first blastocyst culture in the Kansas City area. We did some of the first blastocyst culture in the country, and some of our team members have lectured and published nationally and internationally on blastocyst culture. So first in the late 1990s, and just now some centers are just starting to do it. Here we are in 2013, so that's 15 years ago that we first started doing it. So that's been a really great advance. Embryo vitrification is a type of freezing. You're probably all aware we can freeze extra embryos, but I know that all of you, and I'm guessing this because of patients that we see, will commonly express to us, I'm a little afraid about freezing embryos, and what if they get damaged, and what if they don't survive, and that sort of thing. Newer techniques have evolved in freezing that are softer, gentler, newer, better, which we call vitrification, and survival rate's outstanding, and it's been a really nice advance. And that has just kind of come into being in the last year or two. More recently, embryo biopsy has really become very, very popular. And I'll be talking a lot about that today. And embryo biopsy is a means where we can test embryos for their DNA quality. By that I mean, standard IVF, we grow out embryos and we try to pick the best 1 or 2 by what they look like, by morphology. You could say it's kind of a glorified beauty contest of which ones look the best. And I'll sometimes tell my patients, it's like the Miss America contest. We can either pick the best embryo just on the swimsuit competition alone, or we can add a bunch of other criteria, other things that we want to know, is the embryo good or not? And so this allows us to actually test just a few cells from an embryo and run the DNA, because what we've learned, and you'll see in the slides to come, is amazing about how many are not normal, and we're getting a lot of answers, and a lot of answers that can help couples just like you, okay? It can help just like you, again, with some of those rates, 80% with transfer of one embryo, which is huge. Because IVF is expensive, infertility is expensive, it's heart-wrenching. You heard all the stories, and God bless all of these ladies on the KCIA who came up here and just spilled their guts to all of you, which was very, I'm sure, not easy. But infertility is expensive, but high order multiple pregnancy is even more expensive than infertility. So we're really trying hard to get techniques that not only work for you, but give you one baby at a time, because it's always our goal for you, okay? And the newest thing that has just come up for approval, and just came up in October of 2012, so just very, very recently, is egg freezing, or oocyte vitrification. Now, egg freezing has been done for quite a while, but the pregnancy rates weren't that good, and it was considered experimental. So our center, we were doing experimental egg freezing for this last 18 months or something like that, and then this past October, the FDA came out and said, hey, it's no longer experimental. Huge, huge, huge for you, because there are some women who haven't found their partner yet, or who are not ready to do donor sperm, or some women who have been told by a doctor that they have a medical condition that might require them to undergo chemotherapy, or remove their ovaries, and they think, oh my gosh, I'm at the end of the line, but now we can freeze eggs, and success rates are very high. So these are all, some of these last 3 or 4 on here have really just become available for you in the last year or 2. So that's when I said your timing couldn't be better. If you had that infertility, your timing couldn't be better. Basics of just the IVF process, again, would be ovaries are stimulated. We use different medications for IVF than we might use for IUI, for example. We use medications that oftentimes are injectable. They are often they're often pre-filled syringes in a little subcutaneous needle, kind of like maybe somebody might use heparin or something, but they're quite small. And you usually do the little injection yourself in your skin of your tummy with a little pinch of skin. Anyway, typically ovaries are monitored by ultrasound and blood work, and when it looks like all those conditions are correct, the eggs are gently aspirated under ultrasound guidance in the operating room, usually under some sedation. And typically that entire process really literally only takes about 10 minutes. Later that day, eggs and sperm are put together in a laboratory, either with standard insemination, and that would be putting a number of sperm around each egg, or by ICSI, which is injecting a single sperm into each individual egg. The next day, eggs are checked for fertilization. IVF, standard IVF kind of phase 2 of it is embryo culture. And at this point in time, you are at home, resting, doing nothing, and all of the magic is going on in the IVF lab with lab technicians. And this is a situation where embryos are cultured in dishes in an incubator under very specific conditions. Temperature, gas, media, and typically for 5 or 6 days. Now, not every egg is mature. Not every mature egg fertilizes. Not everyone that does fertilize continues to grow for these 5 to 6 days. So we typically have an attrition. And it may take about a dozen eggs to get about a 50-50 chance of having one baby, and to try to find 1 or 2 nice embryos after this 5 to 6 days. So that's the reason that we use medications to start with, to try to get more than one. We never want more than one baby, but it often takes many to get one golden egg, one golden embryo, so to speak. Phase 3 of IVF involves embryo transfer, and awake and alert, typically, and sometimes mildly sedated, the best 1 or 2 embryos are transferred into the uterine cavity, and often the partner is there, and this is often done under ultrasound guidance. So this is kind of how we've done IVF for quite a while, and then starting in early 2002, we kind of looked like we were kind of parking, like pregnancy rates were going from 10 to 20 to 30 to 40, and then we were kind of parking at this like 60% pregnancy rate, and no matter what we could do, we couldn't get higher than that. And so what we learned in 2012, this was one of the first papers that came out that kind of discussed this, was, those embryos that we thought looked so good and were so beautiful, and then we maybe took pictures of it, even have on our website saying, hey, this is the great blastocyst that we really want for transfer. Guess what? We just found out that when you biopsy a few cells and run its DNA, 40% of those, and that's in the young ages, are chromosomally non-viable and not compatible with life. Huge, 40%. And that's in healthy egg donors, and that's in women under 35. And guess what, by the time you're 40, it's like 75% are abnormal. Huge. So we thought we were all putting in good ones, and we were all looking at the a photograph or at the embryo of the microscope, and so we've learned a lot, and this has really kind of taken our journey this last 1 or 2 years into some of the treatments we have open for you today. So we've known for a long time that the pregnancy rate again, percent of couples who have infertility is 10 or 15%. The chance of getting pregnant on your own, not doing any fertility treatment in a fully fertile couple, is only like 15 to 20% in a month. So we've known that for a long time. We haven't known why. We seem like that seems pretty low. If you've ever been in a traffic jam in Kansas City, you're like, certainly infertility can't be that high because there's all these people. So we thought 15 to 18% of women isn't very high. And now we've learned part of the reason, actually the main reason, that pregnancy rate is not higher per month in any given couple is that there's a lot of bad eggs. eggs, even in healthy women and even in healthy donors, and even more so in couples who struggle with infertility. And the tricky thing is that it's invisible. It's sneaky. You don't know. You're having periods, your chicks are okay, you don't have endometriosis, the sperm count's fine. Everybody's saying it's unexplained. They can't find anything. They told me everything's okay. Well, guess what? If we look a little bit deeper, almost always, ding, 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 we find it. It's almost always in this egg health. Aneuploidy just meaning abnormal DNA, okay? So in this chart, and actually the numbers are now estimated to be higher, but under 35, this is saying oocyte just means egg, that about 10% of a woman's eggs are abnormal. But now we know it's really probably between 10 and 50% even in the under 35. And by 40, this is 30, but we think it estimates between 30 and 90%. So a lot of bad eggs. So sometimes we will use medication, try to get more than one, to try to get that one, again, good one. Now, men make abnormal sperm as well. And if you've ever seen a semen analysis, you'll see like morphology and so forth. And normal morphology is like it's like 5% can be normal. So men make a lot of morphologically abnormal sperm. And they make chromosomally abnormal sperm too. But we've learned in studies that most of the aneuploidy in embryos actually comes from the egg. And egg is almost always a limiting factor. And ladies, you're not the cause, and I'm not either, but the software program has written that the average woman, makes 1 egg in 30 days. The average male makes 5 to 10 million sperm every day. Then there's 29 other days. So they have a lot of leeway. If they make a bad one, they got backup. We don't have backup. So it's not really your fault, it's just the way the software program was written, and we have to deal with the rules. So we use that knowledge in strategizing for you and coming up with some of our treatments. And we know that when there's abnormal embryos, abnormal chromosomes in an egg and sperm, and hence an embryo, that the miscarriage rate is high. Either that embryo is not going to implant, number 2, you're going to miscarry, number 3, and the very last and least likely would be giving birth to a baby with a problem. So we want to try to fix that, okay? Again, this slide is just depicting what I just said a little bit ago, which says morphology is not a good sole predictor of ploidy, of DNA. And that, again, on a day 5 embryo that looks really great, that 40% of those are abnormal chromosomally, even though they look beautiful. And then we look more closely at morphology. And on this chart it says good morphology, percent aneuploid, 45. So 45% are bad, even though they look great. If they look so-so, if they look fair, 67% are abnormal, and that's high. And if they look not so good, 80% are bad, man, we're really getting down to, we really don't have very many embryos at the end of the cycle, even if we stimulate to get a lot of eggs, that really look like they have a high chance of giving you a baby. But the key is, let's try to find that one together, because that's the one we want to put in, that's the one we want to freeze, and that's how we can get you very high pregnancy rates, very low multiple rates, and even your subsequent thaw cycles. If it's one of these embryos, it's normal, it has excellent implantation potential. So, getting ahead of myself a little bit, most of the time when we do biopsy, we'll get an answer. Every now and then we don't get an answer, about 2% of the time when we test a day 5 embryo. So most of the time you do. It's interesting when you get no results. It is more common that you might have an abnormal, by morphology standpoint, poor embryo. Typically when we do embryo biopsy, I'm going to show some pictures of it in just a minute, we do that on a day 5 or day 6 embryo. And at that point in time, an embryo has around 100 cells. And we remove about 5 or 6 of them typically. And the cells that we remove are actually on the very outer portion of the embryo. That very outer portion of the embryo is tissue that has a fancy name called trophectoderm, but it's tissue that is designed to turn into placenta, okay? And so it's important for us to know, is that really indicative of the cells that are going to become the baby or not? Is it the same? Because that's what we're trying to measure. And it has excellent matchup. When we do in vitro fertilization and we look at cycles, we need to have at least one normal embryo to transfer, because obviously if we don't have a normal one, then the cycle's kind of a bust, and then if you don't have an embryo transfer, then the chance of pregnancy is 0, but we would all know exactly why. So it does look like in all comers, if we put all age groups together, about 1 in 5, or about 20% of cycles will not have even one embryo that tested as normal, or they have all abnormal. So that is a risk we have to take. It's interesting, if those couples undergo a second cycle, the majority of them actually crank out a normal one. So certainly data is being accumulated in that area. This is just a graph to show you kind of what pregnancy rates look like, and some of you who have been in this business for a while maybe be familiar with SART. And you can go on SART.org, and there's pregnancy rates of all the centers in the United States. And it's usually about 2 years old because we have to wait until the babies are born and then report stats, and then there's audits to make sure you're not making up numbers and that sort of thing. But anyway, you can look at those statistics. And we, for many, many years since SART was first started, and it was started, I was in my fellowship then, so it was about 96. And it was the first year they had that report to the SART thing. And actually my fellowship, the head of the fellowship was the president of SART. So like, oh, the first year we got to report these numbers. But anyway, all the centers reported as the woman age goes down, that was the #1 predictor over everything. Over weight or sperm count or endometriosis or tubes are blocked or anything like that. Female age is the big predictor. And so typically that's how SART data is reported. And we've all known, and all centers have seen this for many years, as maternal age goes higher, you can see the green line. Can you see okay? This is kind of bright in here, but anyway, there's a green line on the screen. It shows that pregnancy rate is going down, down, down. And what's interesting and so exciting for all of you, or at least I think you should feel excited because we certainly are, is that when we use this technology on women, it's the great equalizer. Because even if you don't make very many eggs, or even if you're older, or even if your FSH is high, or your AMH is low, or somebody said, man, you don't really have great egg quality, which has always been just a hard thing for all of us. If we can crank out one normal one, we can get pregnancy rates in all these ages that are really almost the same as the pregnancy rates using a healthy young donor. So it's phenomenal. Because none of you, I've never had a patient come to our office to say, hey, I want an egg donor. It's kind of that way down, we tried IUI, we tried IVF, we're not getting any luck, what else can we do? And so it's a really nice technology that's available. And again, it's not perfect, nothing is. We've got to have at least one normal one to put in, and sometimes we don't. But when we do, it's really a nice option. The other thing that allows us is, and on SART they also report how many embryos it takes to get a baby, which is a big deal. Because if it's taking you, putting in 3 or 4 or 5 embryos to get a baby, then your multiple chances are high. And so not only are those pregnancy rates really high, if you look on that pink column, those are, it says Natera, those number of embryos we put in is somewhere between 1 and 2. So even putting in 1 embryo, which is a huge thing, because that's our goal. Our goal is always to do elective single embryo transfer if we can. We can't always do it, but if we can, that's really great. So it maintains high pregnancy rates by putting in a low number. So here's the technique that kind of what happens and how it works. That picture, that round kind of blob, is a blastocyst. And what typically happens is, again, basically what we're doing is DNA assessment or chromosomal assessment of the trophectoderm, of the cells around the outside, which is placenta. And on day 3 of an embryo, we do laser-assisted hatching. That AH means assisted hatching. So we make a very tiny hole in the zona, or the little shell, and yes, we have shells in human eggs, a little tiny area so that we can have a biopsy get easier several days later. And then on day 5 or 6, 5 to 6 cells are removed, and they're removed at a very specific stage of development. So this is very tricky. Unlike day 3 biopsy, which we used to do a few years ago, day 5 or 6 again requires a very specific stage. So we can't just look at embryos on day 5 and say, okay, we're biopsying them today. We have to look at them multiple times on day 5, multiple times on day 6 to choose what's the best time to biopsy. So even though there are commonly less embryos to biopsy on day 5 than there were maybe on day 3, it's very labor intensive. And typically the cost is about the same on day 5 as it was on day 3. And again, this enables the study of multiple cells, and that's important because sometimes there's something called mosaicism. Mosaicism is a fancy word to say, if we would just take one cell and run DNA in it, it may or may not be representative of the entire embryo. And so by getting multiple cells, that really increases our chance we're going to pick up a normal versus an abnormal embryo. Okay? Now, whether you can make out all these words or not, this is just kind of a sample report of what one of these things look like. And there's a little graph on here. And normal embryos are on the top, and then the abnormal ones are on the bottom. And again, we're looking for conditions that are non-viable. We're not trying to get the next track star or the next yo-yo ma. We are simply trying to determine viable versus non-viable. Okay, that's really what this is all about. Okay, and so this just kind of, we typically get a report. We commonly use a company called Natera, but there's several of these labs that actually run the testing, and they're all very, very good, and we use several of them. But we would want to choose an embryo, obviously, that's in the viable category. So this, you can see there's some normal ones, and then there's some abnormal, any point being abnormal, and then you can see one of those has no results. And we get a really big Excel spreadsheet, and so for the purposes, it actually tells us every single embryo numbered 1 through, this particular couple had 12, and every single chromosome. It tells us 24 chromosomes. And if you Google something, it would also be called complete chromosomal screening or comprehensive chromosomal screening. And again, this is nothing about making a, ideal society. It's just viable versus non-viable. But we get a read on each chromosome, 1 through 22, X and Y. And X and Y, the reason we do X and Y, they are the sex chromosomes that do in fact determine gender, if you're having a baby boy or a baby girl. But we don't run them to know if you're having a baby boy or a baby girl. The reason they're run is that sex chromosomes are very commonly abnormal. They're very commonly abnormal, and we want to know, okay? So, that's just the other 2 embryos. But anyways, so the outcome data is very good. Doing day 5 biopsy and doing 24 chromosome outcome data, again, pregnancy rates per embryo transfer are extremely high. They're somewhere between, they're in the 70 to 80% range, so quite high, and that's even with transferring 1 embryo, okay? Now, also available and kind of really new and expanding in this last year or 2 is what we call single gene pre-implantation genetic diagnosis. Many of you might be familiar with amniocentesis after you're pregnant, or corneal villus sampling after you're pregnant, to test, hey, is the baby healthy or not? Are we going to have a birth defect, or is it going to be viable, or am I going to have a stillborn and have a birth defect baby, or it's not going to be a healthy baby? And so a lot of technology has increased. So in the last probably decade or so, the American College of OB/GYN has come out and said any couple who's thinking about getting pregnant this year should go see their gynecologist, and they should be tested for, they first started out cystic fibrosis. If you're Caucasian, because that's 1 in 20, it's very common, you could be a carrier, and so we want to know. Well, since that time, many other gene mutations and so forth have become available. And now, if you're a female and thinking about getting pregnant, don't even have infertility, haven't done any treatment yet, then we recommend what's called universal gene screening. And there's various companies who do it. We often use a company called Counsel. There's one called Good Start. There's one called Natera One. But all of what they test is perfectly healthy appearing, normal appearing men or women who have no family history of any birth defects or anything in their family. Guess what we're finding? That, we might be carriers of things and we didn't even know it. And they have no consequence on our health, but they do when we try to make a baby, okay? So finding these are important. And so we started, remember how I said cystic fibrosis, that's 1 gene. Well, here's a chart of all the things we can look for, and the list expands every day. So we'll commonly look for those. And we find things, and if we find abnormalities, then we test the partner, because if the partner has one of these as well, then there's a 25% chance there's going to be a bad baby. So it's a way to, we can not only diagnose a problem, but we can provide a solution. Because 10, 15 years ago or something, when we first started finding these gene defects in women who are carriers, again, asymptomatic carriers, their OB doctor or genetic counselor would see them and say, oh, I'm so sorry. We'll just have to wait until you're pregnant, and then we can maybe do ultrasound, or maybe we can do amnio, and we can see if your baby's going to be viable or not. And if it's not, you'll have a decision to make. Are you going to abort the pregnancy, or are you going to give birth to a baby that's not going to live, and we're so sorry about this. Now, we can provide a solution preconceptually, okay? So, it is possible to do that. It's possible to do genes and the chromosomes at the same time. So here's an example of a couple, and you can see in the very top, they had only 1 unaffected embryo, and all the others were affected for their gene. So that's another technology that's available too, okay? Again, pregnancy rates are quite high when we do this technology, okay? Now, as a little side, I'm going to switch gears a little bit away from embryo biopsy and how to select the best embryo for transfer or vitrification to talk about some other things. So, other things that are kind of new in this last few years would be when couples get pregnant and they're finally so happy and then they miscarry. It's just a heartbreak for all of us because we thought we got there and then we didn't. And so sometimes, unfortunately, women have to undergo D&Cs to empty the uterus of that pregnancy tissue. And we've been able to run chromosomes and DNA on that for some time, but it was always not super accurate because when we do a D&C, we get, incidentally, cells of the female body, cervix, and uterus because you're doing this gentle scraping and gentle aspiration. You can't help but do it. So whenever you got chromosomes that came back 46XX, you didn't know, does that meant the baby was a normal girl or that was mom's cells? So, we really provided, it was a problem. And obviously, half the time it's going to be an XX and an XY, so it's not a small problem. So now there's technology available, just so you know, that would tell us which which cells really came from the fetus and which from the mother, which helps us, if there's an abnormality in the embryo, it helps us kind of sort out what do we do next time to try to prevent that from happening again, okay? The other kind of new thing is once women are pregnant, for those who wanted to do testing, there's now more expanded non-invasive prenatal testing. Again, you guys might be familiar with amniocentesis or CVS, and if you've ever been pregnant before, and we hope that you will be, then what has been available this last 5 years or so is some analyte test. It's a blood test on some chemicals, some hormones and chemicals in mom's blood to try to tell us if the baby's healthy. But it wasn't super sensitive. So now it's possible, which is really cool, to get blood on mom when she's pregnant pretty early and pick up fetal DNA and run the chromosomes on that with no amnio and no CVS, because none of us want to do all this stuff and then get pregnant and then be worried if it's normal or not and try to debate, do I do an amnio or CVS or not, because what if you do one? And, you know, there's a small risk, but it's real of losing a pregnancy with amnio-CVS. Amnio is about 1 in 200, CVS is about 1 in 100. And, you know, you lose a pregnancy, and the next day your results come back that it was normal. Man, that's just a heartbreak. So this non-invasive testing is really pretty cool. And right now, it's kind of complicated. We need some data from mom and dad, but we at least can see 5 of the chromosomes are normal or not, and maybe just by getting maternal blood, and that's really in the first trimester, so it's very, very early, which is cool, okay? Again, pregnancy rates and using some of these techniques are just outstanding. And so it's a really exciting time for me and all of our team to be here with you today. I think it's a great time if you had to have infertility because there's a lot of new things. Again, there's IUI, but in IVF, if you're young, pregnancy rate is outstanding. The older you get, it gets a little lower. Freezing embryos, as you can see, females under age 30, if we looked at our pregnancy rates in 2012, over 80% outstanding. If you're a little bit older, they go down a little bit. Remember we said female age is the biggest predictor. And all ages with a fresh transfer, no matter what age you are, is really high. Donor eggs, of course, is still available for those couples who just don't have ovaries at all, or have had chemotherapy or surgery to remove eggs, ovaries, and did not have the opportunity to freeze eggs in the past, or for those who really just cannot squeak out a good embryo despite all our attempts. And using fresh donor eggs, very high, and actually using frozen eggs as well, extremely high. Frozen egg banks are now available, and that's a huge thing because right off the shelf, literally, you can pick your donor and they can ship us eggs tomorrow. And we can have them, and you're ready to decide. You don't need to worry about who's going to be my donor and what, maybe she's going on vacation, or I'm a teacher and it doesn't gel into summer because my donor wants to do something, she's going on vacation, we can't do it. And frozen embryo trends are very high too. Vitrification has increased that. And again, this comprehensive chromosomal screening, all ages, and here's where the line doesn't look like a downhill, fall into the abyss of doom. Now it looks like it kind of goes straight across, and so it's very, very exciting, okay? So I'm going to just summarize on this slide a little bit some of the new technologies available this last year or two, which again is this laser-assisted, it's very gentle on the embryo, little assisted hatching for this blastocyst stage 5 to day 5 to 6, 24 chromosomal screening for all the chromosomes and with the possible addition of a single gene. Vitrification, which is kind of newer, softer, better, gentler freezing techniques. Egg freezing, the oocyte vitrification is egg freezing, and again for single women, don't have a partner, can't even think about having a baby in the next 5 years, don't want to obligate themselves to using a donor sperm because that really determines the father of that embryo. Freezing eggs is available for prime time. Frozen eggs for donor eggs, and that's huge because again, as I mentioned, being able to have eggs already available and ready, I don't know what else to say, off the shelf ready to go is really been a huge advance. And pregnancy rates are just about the same as fresh. They're very, very close. And some of these other new testings has really been some really exciting things that we've seen this last little bit. I would like to thank my entire team, and I have a team of about 18, and without which we couldn't do anything that we do. So I want to thank the entire team. I work with Mary Ellen Bulmash is in the back of the room. Tony Clark, my business manager, was here just a little bit ago. We have a table set out here. I want to thank all of you for being here, and KCIA, because what a phenomenal group of women and their husbands and men. One of them's running a camera back here, for doing all this for you, because they are busy too. They're taking the same struggles that you are. Now some of them had successes, and I just applaud them, because even after the successes, they're not just like, okay, KCIA, good luck to you, we're going to go on with our lives now. And they're choosing to spend a lot of time and energy to be here with you, because they have elected to really exercise their generosity and sharing those things with you. So, thank you.